On behalf of HealthCert Education, I'd like to welcome you to this evening's webinar. This is the second in a series of webinars we offer our alumni to help add value to their practice and learning, but by providing clinical guideline updates and new information that's easily understood and nice and concise. This webinar focuses on understanding the updated obesity clinical guidelines for primary care. In this webinar, you'll learn about the new clinical guidelines for managing obesity designed to help primary care providers make evidence-based, patient-centered treatment decisions. Before we get started, I'll run through some housekeeping and introductions. So at the end of the webinar, we have a post-webinar survey that provides you with the opportunity to give feedback on the webinar and request more information on any of our courses that might help you in your CPD journey or to subspecialise in a particular area of interest for your practice. For those of you attending live or watching the recording, you may be able to apply for CPD for this webinar, and a certificate of attendance will be emailed with the recording, along with instructions on how to self-submit to your relevant college for consideration of CPD. And with that, let me introduce Dr. Simone Gonzo properly. Dr. Simone Gonzo began working in healthcare as a registered nurse in hospitals throughout Queensland in 2003. After making the change to medicine, she graduated with an MBBS from the University of Queensland in 2010 and gained her fellowship of the RACGP in 2015. Dr. Gonzo enjoys all aspects of general practice, including family health, mental health, chronic disease management, and complex primary care. She also has a special interest in teaching and training GP registrars and medical students. Dr. Gonzo is a champion of general practice and promotes the importance of this specialty in the healthcare landscape. She's currently working on a Master of Healthcare Leadership. And with that, I'll invite Dr. Gonzo to get the presentation underway. Dr. Simone, over to you.
Thank you very much, Campbell. Thanks for that very flattering introduction. I appreciate it. Welcome everybody to tonight's webinar discussing a review of the updated Australian Obesity Management Guidelines and Algorithm. It's a simple tool to guide how we deal with obesity in primary care. So we'll just start with our acknowledgement of country. Acknowledging I'm in Queensland, and we acknowledge the Gubbi Gubbi people as the traditional custodians of the land, recognising their continuing connection to the land, waterways and community, paying our respects to elders past and present. I'd also like to thank HealthCert for supporting this evening's webinar and giving us all these resources so that we can continue our education. So what we'll be learning about tonight is understanding the content of the updated obesity clinical guidelines and applying those guidelines to some patient cases, just to see how we're getting along and how we're managing in primary practice. So there's a little bit about me, but Campbell's well and truly covered that. Thank you very much. Just when we were looking at the guidelines that have been published, it's always good to see who has supported them, sponsored them. These particular guidelines have been developed with the Australian Diabetes Society, the Australian and New Zealand Obesity Society, and also the Obesity Surgery Society of Australia and New Zealand. So there's a few different perspectives that have come together in developing these guidelines. The aims of the document is to help us GPs in treatment decisions for non-pregnant adults with obesity. In saying that, we do cover pregnancy in the guidelines, but that's what they have been developed for. And also just to provide a practical tool to guide how we manage obesity in primary care. As you'll probably realise, there are a lot of options. Obesity is a rising problem for us in the community, and this algorithm helps us make sense of the information that we have. So in looking at where we've come from, the last clinical practice guidelines for the management of overweight and obesity in Australia was published in 2013. So that's 11 years ago now. This has been the nearest update that I could find since that time. So you can appreciate a lot has happened in that space. We've got medications, we've really moved forward in terms of surgeries, as well as understanding the endocrinology of obesity. And however, there's still a lot that we don't really understand. So just trying to get our head around what actually is obesity. It's complex and multifactorial. It's not just as simple as you eat too much. There's lots of drivers behind that. And these guidelines actually do highlight a bit about the environmental. The genetic, I don't think we really understand how that fully determines the patient's metabolism and their overweight and obesity risk. And then there's also the physiological and behavioral determinants that also contribute to that. So some of the figures that we've got are quite aged, so from 10 years ago. However, you can probably just explore those and see how they go over the next few years, and they're probably increased as well. So in 2014, 2015, 63.5% of Australians 18 and over were classed as above normal weight, and 27.9% were obese. So that was nearly 10 years ago. 30% of Australians over 18 years would fit into the obesity category, with the cost of that obesity being at that time $8.6 billion. Obesity is associated with complications such as type 2 diabetes, cardiovascular disease, dyslipidemia, which also leads to other metabolic issues, sleep apnea, osteoarthritis, and certain types of cancers as well. So just trying to split that up into the demographics, you'll notice that in this slide, we are missing the 24 to the 65 year group. But if you just look from the 2 to 4 years old, we start off with 1 in 4 being obese or overweight. And then as we age up into 18 to 24, becomes 1 in 2. Then 65 to 74 becomes 4 in 5. Now this category, although it is included in here, the over 65s, we have to treat slightly differently because the metabolism is slightly different, and there's also other factors that we need to take into account when we're looking at obesity in that population. So with the diversity, looking at marginalised communities, we've got people in most disadvantaged areas 1.16 more likely than those living in areas of least disadvantage to experience obesity. Men are 1.25% more likely than women, which I thought was a little bit surprising given the hormonal sort of factors and things like that also differentiate between genders. People with activity limitations. So those of you that look after patients that are in care or live with cognitive issues or require higher levels of care will realise the challenge it is in keeping patients at a healthy weight. In those categories, there's behavioural issues, care issues, restrictive practice issues, things like that can get a little bit interesting to manage. And then if we look further at the Aboriginal Torres Strait Islander communities, we've got the overweight and obesity contributing to 7.2% of the health gap between Aboriginal Torres Strait Islander peoples and non-Indigenous Australians. So there's just a couple of populations there that I think were a bit surprising when you look at the people that we should really be targeting in obesity management. So just touching a little bit more on Aboriginal Torres Strait Islander communities. Once again, we've got numbers that are a little bit old now, but 71% of Aboriginal Torres Strait Islander people 15 years and over had a BMI in overweight or obese range. So that's a significant number. But what I found interesting was if we look at the figure down here, overweight and obesity rate amongst Indigenous Australians, it was actually highest in inner regional areas and lowest in very remote areas. So although there's still only 62%, versus 76%, it's interesting to see that when we talk further about behaviours and environmental factors and marketing and things like that, could that be because inner regional areas, we've got much easier access to fast food, or perhaps, you know, there's more funding around, or you know, people are a little bit more affluent in terms of being able to get there? Or is it in the very remote areas, there's more of a traditional diet being consumed by the people? So we've also got the proportion of Indigenous Australians increasing from 66 to 71% in that period from 2012 to 2018. So you can see that's increasing as well, which is also going to be causing problems with diabetes and kidney disease and cardiovascular issues as well. So moving on to the actual algorithm. This is the algorithm. It's a very busy slide, so it does have a lot of information, and we've tried to blow it up as much as we can. It divides BMI into 30 to 39 and then greater than 40. And then it works down from the top to the bottom, the baseline assessment for complications. If complications are present, you fall into the right side. If complications are not present, you fall into the left side. And from there, it works down through the different areas of treatment. And obviously, just on an overall one there, you can see left to right, less severe, more severe. As we go down, we end up from, you know, nil treatment or just being able to be managed in primary care, right through down to bariatric surgery specialist areas of interest. So this document is an 87-page document. It was prepared with the input of the health ministers meeting, and it was derived from a 2022, and it's to lead us through the next 10 years as a plan as to how we're going to manage this health issue. This is another busy slide, but I thought it was good to be able just to introduce into our talk tonight. You can see how we've got 3 ambitions that we're heading for. The first one on the left is ambition 1, which is much more community-based, and that's community groups, schools. We do have something to do with that as general practitioners, governments and education. On the ambition 2, empowering people to stay healthy. So that's about improving skills and knowledge. We also contribute to that. However, our main area of focus as GPs is access to early intervention and care. So enabling better access to health services and programs, address and treat unhealthy weight, and getting patients back into a healthy weight range so that we can improve their long-term health. I'll see if I can, yep, there we go. So we're all good again. So the challenges of this, the root causes are complex, it's difficult, it's embedded in the way we live, and it's not simply a lack of self-control. We do have to watch our own bias when we're dealing with obesity and behaviours involved with obesity. An important thing to remember is that unhealthy food and drinks are cheap and convenient, heavily promoted, available almost everywhere. Some instances cheaper than healthier alternatives, and they are normalized in the way that go through the drive-through, here's your breakfast, here's your coffee, and there's a stack of calories to go with it that we probably need to just be a little bit more aware of. Our sedentary way of living, we're all behind a desk a lot more than we used to be. There's not as much time for incidental exercise, moving around, and you know, things like webinars are great, but it cuts out a lot of that travel, and we're spending so much time either at working from home in a desk that it just takes away all of that incidental exercise. So preventing obesity, I feel that as GPs, we're in an excellent position to try and prevent things before they happen or become a problem. We see our patients a lot more than any other health professional does, and we have an opportunity to be able to sensitively discuss and assess and refer these patients. And that could basically reflect back on our long-term relationships with our patients as well. So we've known these patients for a long time. So you can sensitively bring up that, oh, we probably should start watching your weight, seeing how things are going, and also reflecting back on if they've got cardiovascular disease risk or diabetes as well. So screening is the first line of prevention and weight management. And there's possibly a few of you that don't feel comfortable raising weight issues or aren't aware of the support or referral options available. Clearer models of care, so having a bit of an idea about how you would manage someone with their obesity can also help improve the patient journey and health outcomes. In terms of screening, I often weigh and measure most of my patients close to nearly every visit, especially the children, and that just becomes normal. So they know when they come to see the doctor, we hop on the scales, we check their height, see how they're growing. It's also a really good tool to show parents, because on our software we should be able to track that on a graph, so you can show how that child or infant has been growing and tracked from 6 months of age up to now 5, 6, 7, and you can see how they're moving up through the different centiles, and we better start watching the weight, and how's the sport at school going, and are we eating a little bit too much fast food and fizzy drink? And yeah, it's just a way of opening that up. Unfortunately, it's also a way of sometimes goes the other way. I know this is an obesity webinar, but I also find that by doing regular weighs and measures, it helps with our eating disorder patients, especially adolescents, because they know when they come to see their regular GP, they hop on the scales and it's nothing out of the ordinary. It's what we do all the time, checking their growth. So the main recommendations and changes in management, the treatment pathways should be determined by a person's BMI and their waist circumference as well, and also the presence and severity of obesity-related complications. So just reflecting back on that very busy algorithm, you'll remember that it had the left and the right, and then we worked our ways down through any complications. So the first one on the left-hand side is reducing energy intake. So this is one of the treatment options. There's a few of these you'll notice on that algorithm. There's reducing energy diet, there's a low energy diet, and a very low energy diet. So red, LED, and V LEDs. So in our reduced energy diet, which is on the left-hand side of the algorithm, we're looking to reduce, just have a deficit of 2,000 to 4,000 kilojoules a day, and also increasing the intake of vegetables, fruit. We need some protein in there, minimizing the intake of discretionary foods. You can also use a dietitian to help out with this sort of thing. If people have eating likes, dislikes, celiac, lactose intolerance, anything like that, dietitians are a great wealth of knowledge in terms of getting our deficit in there. And the low energy diet is looking at reducing our total daily intake to 4,200 kilojoules to 5,000 kilojoules, depending on male, female. And with that one, there is a much more prescriptive diet, and specific meal plans should be obtained from dietitians. In Australia, we've got things like Light and Easy and food providers that can also give you diets. They are not cheap, but for a certain amount of time, it can be good to start motivating that weight loss, and patients can see a change, and often they want to keep going with that. This can also be done by substituting 1 or 2 meals with the meal replacement. So these can be the shakes, and there's lots on the market, and it can come down to cost, like, dislike, what's available. So yeah, there's a few different options there. Often when we're looking at this algorithm, it's an idea or a guideline. It's not one or the other. Sometimes we will be using a few of these strategies, and sometimes over the journey with the patient, the strategies will change. So in terms of our very low energy diet, this reduces the energy intake to less than 3,000 kilojoules a day, and that substitute meals with formulated meal replacements. So generally that is 2 meals a day being substituted, and the VLEDs tend to be low in carbohydrate. So that induces a ketosis, which also has an anorectic effect after 2 or 3 days. So patients' appetite tends to drop off a little bit. So often bariatric surgeons will use this as a preparation before they do their bariatric surgery on the patient. And that's basically to get the liver a little bit smaller so that they can maneuver around it to do their surgery. So in practice, our very low energy diet is recommended for up to 12 weeks. It can be continued for longer under supervision, and that depends on the baseline and weight of the patient. We'll be presenting tonight the research and findings that have also come out that were in the guidelines, and seeing what's successful and what isn't as successful. So most of, if adhered to, which is the biggest problem, if adhered to, the VLED can produce a 14.5% initial body weight loss after 8 to 20 weeks. So, but it is a very hard diet to adhere to for that length of time. At 1 year, the metabolic parameters, so liver function tests, fatty liver, glucose, that was all improved in all of the studies that were done. So with all of the interventions, regular clinical review is essential, occurring at least monthly. And as we said before, you can use a combination or a partial regime with your VLED. And if we have 2 meal replacements and a serve of lean protein, that's how we would get our weight loss with the very low energy diet. To reduce the risk of gallstone formation, we like to add in a teaspoon of olive oil. So when you have a significant weight loss or a massive, in some cases we call it massive weight loss over a short amount of time, you can develop gallstones, and by putting the olive oil in, that reduces the risk of that. So contraindications to the very low energy diet: pregnancy or lactation. Severe psychological conditions. This can be a problem because it is such a restrictive diet. So it's restrictive, it requires lots of discipline, and we need to just be mindful of that in terms of how patient is coping psychologically with that. If they've had a recent myocardial infarction, cerebrovascular event, or unstable angina, that's also something we need to worry about. And the porphyria, that's interesting. I had to look at that. Apparently it, by reducing the intake of carbohydrates and energy in an effort to lose weight, can worsen those diseases. So there's been a few cases of severe acute attacks of porphyria have occurred in patients who attempted to lose weight rapidly with very low energy diets. And also in the over 65s, there's limited safety data for such a strict diet. So we'd probably have to go a little bit careful with that in terms of having such a very low energy diet. Special groups, patients that are diabetic on insulin, we'd need to reduce their insulin intake by 50%, and also just titrate their insulin requirements depending on their blood glucose levels, especially having such a reduction in carbohydrates. And the SGLT2s, monitoring ketones, or consider stopping those medications while using the very low energy diet to reduce the risk of ketoacidosis. Chronic kidney disease, they need closer supervision as well, and also patients that are on warfarin. And it's not so much the quantity of green vegetables that's the issue with warfarin. It's the level of intake that must be kept constant throughout it. So once you've made that dietary change, things should be stable. It's just getting there that can be the issue. So increasing our energy expenditure, that's our next unit to look at. So what goes in has to be expended somewhere, somehow. As we've already sort of summarized at the beginning, physical activity, we need to increase that. We've seen with the injectable medications that there is a risk of sarcopenia, so that's losing your muscle mass. If we do anaerobic resistance exercise, light weights, that can reduce that. And also we need to improve our cardiovascular fitness. If we have the elderly population or people with musculoskeletal problems, they may benefit from a water-based therapies, or even things like yoga and Pilates, and can be a start for some of these patients who are so obese that it's actually difficult to move. But if we can get them comfortable with actually moving their bodies, we can slowly start to work up. Individuals with cardiovascular respiratory disease, they may also need a gentler regime. So often in practice, it's about finding something the patient enjoys. If they enjoy walking the dog, if they enjoy playing with the grandkids, build an activity in with the grandkids that involves taking the grandkids for like a ride on their bike, so the patient gets to walk as well. It has to be something that they look forward to, because if it becomes a chore, then it sort of drops off and they lose a bit of interest in it. Exercise physio can also help, and so can physiotherapy through your GP care plans within the community. So we can get subsidised exercise physio for patients to help with some exercises if they have difficulties. Now, the big one, the pharmacotherapy. There's been a huge change in this space, probably in the last 2 to 5 years. We've had quite some developments, and pharmacotherapy should also be used with the exercise, the weight, the diet control. You can also use it with the weight loss maintenance, the low energy diets, swapping in some shakes, and we'll go through and see what that has to offer. So in Australia, we have 5 medications that are approved by the TGA for obesity, treatment of obesity. Duramine, and I've tried to sort of arrange these in terms of chronological order. So Duramine, phentermine, that's been around for many, many years. Daily tablet, Xenical, which is also a tablet, and liraglutide, Saxenda, so that's a daily injection. And then we have the naltrexone and bupropion, which is a twice daily injection. And most recently, we've got semaglutide, which is Ozempic for diabetics, or Wegovy privately. So they're the medications that have been approved in Australia. We'll go through those and have a look, and then we've got some off-label medications as well to have a chat about. So with the Duramine, it's a centrally acting adrenergic agonist that suppresses appetite. It's an old-fashioned stimulant. It can induce tachycardia, hypertension, insomnia, can give you some poor sleep. We need to watch it with antidepressant medication, and also patients that have had problems with mood disorders in the past. With any of these medications, we start low and go slow. The Duramine is registered for short-term use, so 3 months. And so you can generally take it every single day for 3 months, then have a break, and then you can start it a couple of days later for another 3 months. That you can build in a bit of flexibility with dosing, especially when it's an oral tablet. Some patients find they take their phentermine or the Duramine Monday to Friday, they have their weekends off, have a bit of a break, find that gives them a little bit more real life usage out of it, and also it's cheaper, so they get a little bit longer out of their script. You can achieve a weight reduction of 5 to 10% on 12 weeks of ideal treatment with the Duramine. Once again, if you stop the Duramine and no behavioural change has occurred, the weight's going to come back on. So our next one, Orlistat. So that inhibits pancreatic and gastric lipase, which reduces fat absorption. This is possibly a little bit more socially embarrassing. Side effects including steatorrhea, oily spotting, flatulence if you have more than 30 grams of fat. You can also, because we're not absorbing the fat with the Orlistat, the potential long-term complications and deficiencies of fat-soluble vitamins A, D, and K, and then development of kidney stones. So that's something that possibly is a bit of a deal breaker in using the orlistat. Some studies with that one report a weight loss of 10 kilos at 1 year and then 5 at 4 years. However, a 37% reduction in progression to type 2 was also reported with the orlistat. Getting people to use the orlistat over the length of time tends to be a bit of a problem. Liraglutide. So this one is our Saxenda, and it's a once daily GLP-1 that slows gastric emptying. All of the GLP-1s work in that way. So that's how they deliver their different effects. The starting dose with the liraglutide, 0.6 milligram daily. Patients inject this themselves and then they increase the dosage every week. Now, I do prefer my patients to start at that starting dose. You may not notice any effects in terms of weight loss. That's fine. We want them to be able to tolerate it. So with these medications, as a class of medications, you can have basically a gastroparesis. So that we've got our stomach contents sitting in the stomach. They can have reflux, GORD, chest pain, water brush. In some cases, we need to watch out for things like pancreatitis. But if we go very slow with this, we generally can reach a dose that is not problematic if we do have those side effects, or we find that we reach the dose that we are achieving the desired weight loss rate. So when we do take these medications, we also need to look at the glucose lowering the other glucose lowering medications that patients may be on, so that we don't make them hypoglycemic. So yeah, the common side effects with these medications, with the Saxenda, is nausea, vomiting, constipation, diarrhea. And that's pretty much the same for all of the drugs within this class, because of their mechanism of action. Saxenda in particular increases the risk of gallstones, and some cases of cholecystectomy are required with that. So, but yeah, it's the pancreatitis that we need to watch out for. Moving on to our Contrave, or the combination tablet, which is naltrexone bupropion. So we don't really know what the mode of action is with both of these medications. It's to do with hunger system and the mesolimbic rewards. With this one, it does tend to work similarly to the GLP-1s in terms of slowing our gastric transit down, and main side effects, nausea, vomiting, and constipation. And also with this medication, we increase the dose. So we escalate that, going from 1 tablet a day, and eventually you end up on 2 tablets in the morning and 2 tablets at night. So often with some of these medications, we don't understand how they work within the brain, but we find that people who quite like alcohol don't tend to like it as much. The same is not been found with cigarette smoking, but definitely in terms of alcohol, things like chocolate and all the sort of food chatter tends to quieten down with these medications. Ozempic and Wegovy, same medication, same active ingredient, semaglutide, is in both of these products, different doses. In Australia, we still prefer to use Ozempic or semaglutide low and go slow. We started at 0.25 milligrams weekly, moving up. Eventually you can get to, most patients will possibly only tolerate 1 milligram a week of the semaglutide. If we get patients much past that, they tend to have too many side effects. So generally the 1 milligram per week is generally enough. And as you've probably all read or aware of, we've had some fairly sensational results with the semaglutide in the right sort of healthcare supervision, lowering blood pressure, improving lipid profile, glucose levels, physical functioning. Even the CRP can be reduced, because that's basically the inflammation that obesity causes. We can reduce that. So it can also reduce the risk of stroke, cardiac causes. The side effects are similar. However, the Ozempic or semaglutide also, we need to watch out for diabetic retinopathy in people with a pre-existing history of that condition. Any worsening of diabetic retinopathy is apparently related to the fall in the glucose levels. So that's why if they're a diabetic patient, we'd like them to have their regular optometry, at least reviews annually. So now we'll move through to our off-label pharmacotherapies. We've got topiramate, the combined low-dose phentermine and topiramate. They don't come in a combo drug in Australia. They are separate medications. And then there's the Mounjaro, which is also a GLP-1. So topiramate is an anticonvulsive medication. It's a powerful appetite suppressant, but it gives you some quite significant side effects like depression, difficulty concentrating, people feel a bit foggy. And it can be used, but I think it possibly is falling out of favor now with the other medications that are becoming so handy to use. The combined low-dose Duramine and topiramate is also a good combination. However, the tolerance of that in terms of the side effects is generally a problem with patients, with that nausea and just feeling foggy with the topiramate. Oops. The Mounjaro or the tirzepatide, that's one of the newer medications. It's approved for type 2 diabetes, not for obesity. It's approved for obesity management in the USA, Europe, and UK, and it's also been shown to reduce those metabolic markers, blood pressure, improve lipids, reducing glucose. It reduces the sleep-related issues as well, and it also has similar side effect profile, including nausea, vomiting, constipation. The Mounjaro in Australia is the more expensive of the GLP-1s, and it comes in a vial, not a pen that the patient can actually inject themselves. So the delivery of it is a bit more difficult. The cost is also a bit of an obstacle. So it possibly hasn't had the success they might have wanted for that particular medication. So moving through to bariatric surgery. It is still the most efficacious weight loss intervention for the treatment of obesity, and it should be considered as part of a comprehensive treatment with multidisciplinary team. So often people get to bariatric surgery once they have tried everything we've already discussed, the low energy diets, nowadays they can try the Ozempic, and it's also a very individualized decision. And the surgeon should be viewing that patient as an individual as well, and making sure that they've had the right psychological dietitian and even some exercise physio input so that we can optimize their outcome after their surgery. So with the new algorithm, it does discuss bariatric surgery and suggests that we have the components of a successful surgery. Informed patient, they really do need to do their work, and that's not just social media work, that is psychology, maybe going to one or two surgeons, finding out what is available. There's a few different surgical procedures included in the bariatric surgery. That operation is tailored towards them, and we also optimize their health prior to the surgery. So that includes things like stopping smoking, managing their sleep apnea if that's an issue. Some surgeons will like their patients to have that very low energy diet so that we can shrink the liver down a bit to make it easier for them to maneuver inside the abdominal cavity, and also providing them with long-term follow-up. That's quite important in terms of dietitian advice. So there are still some post-op complications that can happen with bariatric surgery. And if the surgeon offers a very comprehensive follow-up, it does put the patient at a better outcome profile. So the surgeon does need to do a careful risk to benefit assessment and optimization of health prior to surgery. And you'll find the surgeons that are interested in that as a more holistic sort of field. So in terms of bariatric surgery, there's a couple of different sources and their opinions, and they all tend to agree. The NHMRC clinical guidelines agree that bariatric surgery should be considered or may be considered with patients with a BMI over 40, those with a BMI over 35 and comorbidities that may improve, and those that are over 30 with poorly controlled type 2 diabetes and cardiovascular risks that can be improved as well. So we're kind of trying to get patients before they get into more serious trouble. If we can manage that obesity before, we give them a better outcome. The Australian Diabetes Society also endorses that or agrees with that. Their cutoff is greater than 40 for their BMI, regardless of the level of glycemic control, and they agree that 35 to 39 also with inadequate glycemic control, despite all of the lifestyle and optimal medical therapies that have already been tried. And we also talk about our oral or injectable medications, including insulin for patients that are with a BMI of 30 to 35. So how do we use this algorithm? Just going back to having a look at that, you can see how it's divided left to right. We've got our waist circumference there, and we've also got our baseline assessment for complications here. So if we move through and look at categorizing it, we split it between 30 to 40 and then greater than 40 and the presence of abdominal obesity. As I've already summarized tonight, the association between BMI fat distribution varies according to race and age as well. So it's not just one figure, one number that we need to look at when we're talking about the severity of the BMI, but we need something to guide us. So the abdominal obesity, also difference between sex and between genders and age. And although it does tend to increase, the abdominal obesity tends to increase with BMI, some people with a BMI in the normal or overweight range may have abdominal obesity, especially in the elderly in association with sarcopenia. So you can often see that where they've got the rounded sort of more barrel in the abdomen and the skinnier legs, and they actually might be still a reasonable BMI. Gold standard for measurement of abdominal fat is with a CT or MRI. The waist circumference measurement with the good old tape measure gives us an estimate of metabolic disease risk. So there's no consensus on the optimal protocol for measuring the waist. There's a standard in this particular guideline that says either at the midpoint between the lowest rib and the iliac crest, the level of the iliac crest, or the narrowest point of the torso. So you can see how that would vary according to the individual. And the important thing is the consistency of the measure. So if you always measure your waist measurements the same way, just keep doing it. Don't kind of chop and change, because if the practitioner is consistent with how they do it, that also means that their records will become consistent as well. So the Heart Foundation actually had some quite good information about who these measurements apply to. So, and their statement is that the waist measurements should only be used for adults to check their risk of developing a chronic disease. So that can also be an indicator, as well as BMI, in terms of, is this patient at risk of developing a chronic disease like diabetes, cardiovascular risk. So assessing for the obesity-related complications. So that's fairly, straightforward in terms of knowing our patients. The complications are grouped under medical, psychological, and physical limitations. The majority of individuals with a BMI over 40 will have obesity-related complications. So some complications more responsive to weight loss, and you'll see that the liver function improves, PCOS can improve, blood pressure can drop as well. We want to set our weight loss targets. So the algorithm sets out a weight loss target of 10 to 15% in individuals with a BMI 30 to 40, and then greater than 15% in those with a BMI over 40. This changes as well. Some patients will have a particular weight in mind, 20 kilos, 30 kilos. They're indicative only. Personalised weight loss targets should be set. Lesser degrees of weight loss can have medical benefits, especially in diabetes prevention. And I often say to patients, if we just get 5 kilos off, just start with 5 kilos, get 5 kilos, then we can move again and again. We can, before you know it, you'll get to 10 kilos, 15 kilos. Even that is a help. The interventions in terms of healthcare services, so GPs were ideally placed to manage the care of people with obesity, and within our realm we've got access to dietitians, diabetic educators, exercise physios. A lot of the private health funds now will subsidise patients' gym memberships. So they're the interventions that we should be able to provide to patients. And with the management of BMI over 30 to 40 without complications, so that's on the left-hand side, supervised lifestyle intervention, that's where our red or lead low energy diets come in, and increasing our exercise, referring to dietitian, exercise specialist, lifestyle coach even, or even an established commercial weight loss program. We have Light and Easy or something similar. That can be considered. And then if we're not getting the weight loss that we want, we step it up a little bit and can think about having some pharmacotherapy. Once we're moving into the higher range, our choices, our options become the very low energy diet, pharmacotherapy, and or bariatric surgery. You can use one or both of these in combination. Yes, some patients, bariatric surgery isn't always the endpoint. Some patients do end up having bariatric surgery, and then after so many years, they have gained more weight, and we then have to talk about pharmacotherapy or a different procedure for their bariatric surgery. Over 40, they should be considered for intensive medical interventions and managed in specialist care. So that's to bariatric surgeons. Unfortunately, here in Queensland, we have not that great of a public system for that. So it basically is a private market that we're referring patients to. But yeah, we sort of need to cut to the chase when we have BMI over 40 with obesity-related complications. That is a very difficult conversation to have with patients. Hopefully you've addressed that situation before we got to greater than 40 with obesity-related complications. But with some patients, they're aware of it, and it's just a no-go, or there's lots of different obstacles or reasons why they are in the mindset they're in. So special clinical situations, age, the nadir for lowest mortality associated with weight isn't constant, and it varies with age, ethnicity, and presence of other disease. This is where we were talking about over 65 years having different risks. So if you're obese and you're over 30, your BMI is over 30, it does not appear to carry the same mortality risk in older adults. So that's where we do need to be careful with the aged in terms of driving a really strict diet. We need to have a little bit of flexibility with that. And healthy aging should focus on lifestyle, quality nutrition, and fitness as well for joints and mobility, independence. Young adults 18 to 35, rapid weight gain in this particular phase, and that's normal physiological changes, but it can also coincide with the end of school-based exercise activity, more study, university life, more sedentary, moving out of home, less sort of regular meal times, and we can have big weight changes in that time. We also need to look at the early intervention and detection of that. So that's where it comes back to the regular weights of patients as they come in, hopefully still, going to their regular family GP for that sort of thing. And just having quite sensitive words saying, oh, we should watch this. This is where you were when you were this age. Let's see where we are there. What's changed? Can we get you moving a little bit more? Older adults, the over 65. So definitely research is not as robust, and there's no clear BMI target in this group. This mainly comes down to physical function, minimizing the impact of obesity-related complications. So we need to keep people moving, keep their independence, reduce their risk of falls so that we can manage their health long term. Yes, so we're maintaining their health, physical function, weight gain, and we're looking for a more moderate intentional weight loss. So ideally 0.5 kilos to 1 kilo a week is nice and steady, and that kind of prevents that sarcopenia effect happening. Cardiovascular fitness should be considered in the older person as well. So they may need things like pool-based therapies, hydrotherapy, and that should encourage them more social activities. So pregnancy, obesity during pregnancy associated with increased risk of obstetric complications, hypertension, fetal macrosomia as well. So we are not wanting to lose weight so much, but we just don't want to gain it in pregnancy. In women with excessive weight gain, weight management strategies should be implemented. So it's about just making sure that our gain is not excessive. If a patient is looking at bariatric surgery, ideally 12 to 18 months before a pregnancy is considered. It can happen that they have their bariatric surgery and 6 months later, then we diagnose a pregnancy. That needs to be managed by a specialist right from the beginning of that pregnancy, and specialist obstetrician, and also a close liaison with their surgeon, their bariatric surgeon. The medications that we've discussed, category B for use in pregnancy, and the GLP-1s are category D for use in pregnancy in Australia. So let's move through to our case study. I know we're pushed for time, but we'll move through and see how far we get. So we have Laurel. She's a 28-year-old female, 180 centimeters, 175 kilos, BMI of 54. She is very tall. Her family is a very big build. She's single, lives with her family, works full time. She's 28. So over the years, she's tried everything, as most of these patients have: the gym programs, exercise, low carb diets, the green diets, the shakes. She's lost a little bit of weight here and there, but it's always quickly regained. So she's a little bit sick of this and comes to see us. So working through our algorithm, we find that she is up in the right-hand side here. She doesn't have any complications at the moment. So we're looking to lose around 15% for Laurel. Primary care and or specialist care, intensive interventions, generally a very low energy diet. She's kind of done that. She hasn't really done much of the pharmacotherapy. We'll give that a go and we'll see where we are with that. And we may either head down this path with Laurel, or we may head down that path. So moving through, she's got a BMI greater than 50, no complications. We've worked out our target weight loss is 15%, which is greater than 26 kilos. Doesn't sound like much, really, does it, with a 175 kilo start? But if we can get 26 kilos off, that is what's classed as significant. So we'll do a GP management plan. We'll get her some help with a dietitian, exercise physio, and also start her on a very low energy diet. She manages to lose 12.5 kilos over 15 weeks. It's intense for her. So she's doing okay. She's got, halfway to her target. However, she changes roles at work, becomes more sedentary. So she used to be more active. Now she's working more sedentary behind a computer. Her weight goes up again. She's in an office surrounded by morning teas and things like that. So looking at where she is now, we're back here at the very low energy diet. She's kind of oscillated between here a little bit. So we're going to look more at pharmacotherapy for Laurel. So what will we choose? We've decided we're going to add in some pharmacotherapy. The decision's basically up to her. She doesn't have any contraindications to any of the medications. And so Laurel chooses a once per week injectable off-label, the semaglutide. She's trialing that. Over the next 3 months, her total weight loss is 25 kilos. Better to target. She's getting there. She has slowly increased her dose of that, but hasn't really had any side effects. So she's been okay on that. So she gets frustrated at the up and down, the yo-yoing. Her life is governed by food choices, exercise programs, no time for anything but work, diet, exercise. So she's feeling a little bit frustrated with her situation, and is this her life? Comes to you after a few months. What do you think about weight loss surgery, doc? Am I taking the easy way out? What do we think as GPs? We have to look at our own biases, our own beliefs, put that aside. What is the best for our patient? She's tried as hard as she can with the treatments to date, the VLED, the pharmacotherapy. We have a discussion about risks and benefits, and she wants to talk to a bariatric surgeon. So a referral is made. In our environment here in Queensland, it's more likely to be a private surgeon. So we send her off to look at a couple of different surgeons, and she decides that she's going to have a chat to one. So she's seen a surgeon that she likes the sound of, very compassionate. She wants to go ahead with the surgery, and we're happy to support her in that. She has a surgery, and we review her at 10 days post-op. Nil nausea, wounds are healing well. She's adhering to the prescribed diet post-surgery. We look at her at 4 weeks post-op. She's back to work. She's finding her normal routine now. She's since lost 10 kilos since the surgery date, and felt like she hasn't really tried to. It's just been happening. At 3 months post-op, she's lost 30 kilos of weight loss, which is above her target. So she's reached her target at 3 months after her surgery. At 12 months later, she's now lost 70 kilos. This is actually a real case study of a patient of mine. These are her numbers. She did lose 70 kilos, and it basically has changed her life going forward, especially with her age. So at 18 months, she now weighs 95 kilos. She can't remember when she was last under 100 kilos. So her BMI is still 29.3. So she's still classed as overweight, but for her, it's been a life-changing improvement to her health, and yeah, has totally changed her pathway going forward. She lost in total 80 kilos. So in summary of our obesity management, you can see how complex it is. There's a lot of options. There's a lot of interventions that are available, and it takes a lot of investment and a lot of time on the GP's part in working with the patient. It's not a one size fits all, and it's not a quick fix by any means. As GPs, we need to be proficient in managing obesity for our patient cohort. This is something that can affect all patients, and you've seen the percentages of patients that do experience obesity. We need to apply these strategies and management. And as always, we need to look after ourselves. We do need to apply some of this to ourselves in terms of exercise, diet, all of that sort of thing, just making sure that we are looking after ourselves. So that's just our references. And I think we've just gone a little bit over time, Campbell.
Well, thank you, Dr. Simone, for that insightful and very interesting presentation. We do have a few questions have come in. Going back to the beginning of the presentation, you mentioned discretionary food. Can you just give us a little, explain that a little bit more? Discretionary food was one of the things I think you're talking about in when your patients come in and you might first have a conversation with them.
So that's all of the extras. So if you think about their meals as being your traditional sort of 3 meals a day, discretionary foods are things like the morning tea, the vanilla slice, fizzy drink. So anything sort of carbonated, fizzy, sugary drink, even juices. They're classed in the discretionary sort of food, and high calorie content without a great nutritional content there.
Fantastic.
So, yeah.
I think that answers that question. Sally writes, does obesity alone qualify you for a GP MP?
The management plan has got, if you actually look at the Medicare rules for that, It's a chronic disease, and the chronic disease has to be present for the previous 6 months. And there is not a list of chronic diseases. So obesity is a disease, and as long as the patient has had it for 6 months, yes, that can qualify.
I think that answers that question. It's how long can we keep a patient on naltrexone slash bupropion?
Yes.
Can we prescribe it with antidepressants like SSRI?
You can prescribe them together. You just have to be mindful of any mood changes, and that's why with that medication, also known as Contrave, is that you start slow and work up. So with that particular medication, you start at 1 tablet a day, and then you start the next week 1 tablet morning and night, and then the next week 2 in the morning, 1 at night. So you increase it very slowly, always mindful for any mood changes that may happen. If you are getting a mood change or the patient doesn't tolerate it, you either reduce the dose back down to something that they can tolerate if they are having weight loss, or you just abandon that one altogether and look for something else.
Right. Another question on pharmacotherapy, which you may have addressed. How long can we use Wegovy?
As far as I can tell from the literature, there is not a length of time with that. If you think about diabetics, they're on the same medication, the semaglutide, indefinitely anyway to manage their hyperglycemia, their diabetes. So in theory, there isn't a cutoff point to use the Wegovy. However, I still think it's sensible to have a target weight in place. Often in general practice in real life, you see that patients either pull it up because of financial cost, or they're just sick of doing it, or they just want to try something different. And often with a lot of these interventions as well, it's worthwhile just recognizing that often patients will do something for 3 months, they'll have a break, they might go back on it again. So over the course of a few years, they might sort of increase a bit of weight, bring it back into check, things get up, off the rails again. So they have that cyclical sort of behavior with these medications, treatments.
Fantastic. And thinking about bariatric surgery, Stephen, right, what's followed up after bariatric surgery?
I missed the first bit of that question, but I think you were asking about
Yeah.
follow-up.
So thinking about how long would you follow up a patient post bariatric surgery?
So the guidelines or the recommendations from the surgeons, I've just had a patient who was discharged from one of the pioneers of bariatric surgery in Queensland here after I think it was something like 10 or 15 years. His surgeon finally discharged him. He is now in my care, and he's to have annual bloods anyway now going forwards, and looking at those, especially those fat soluble vitamins A, D, and E, to make sure that they're all fine, and they have been fine anyway. But generally, if you're aware that your patient has had bariatric surgery, annual bloods is basically enough after, say, 5 to 10 years.
Okay, great. Thank you. Couple of questions that are a bit, so still on bariatric surgery, and you've mentioned cost a couple of times up here in Queensland. It's out of pocket, any chance of getting covered by Medicare? But more broadly to that, Heidi also feels the guidelines are very lopsided to the treatment of obesity, which is often costly, inaccessible, and massive barriers in regards of motivation and long-term success.
Great.
Can you make any comment about why they might not have included a more realistic algorithm where we assess for causes of obesity and educate people? How can we, and then probably more importantly, how can we as GPs get more resources for allied health to people?
Oh, that's the $1 million question, isn't it? Is the allied health. There's very few allied health that actually bulk bill even on a care plan. I think dietitians and even diabetic educators, they're like $190 to $120 per visit. If you can get on a care plan, it might come down to say 40, but still, if you're paying for medication, things like that, it really reduces the amount of engagement you can have with that allied health. And I agree. This is a costly, expensive chronic disease to have, and it's not funded as well as some other diseases are funded. So yeah, to the beginning of that, I also think that this guideline is addressed at how we manage obesity as already being an existing chronic disease in terms of how we prevent it. That is touched on a little bit in that earlier concept map with the overall strategy. So the overall strategy, the obesity strategy is 87 pages, and part of that is on health promotion, prevention. But as GPs, this is just our focus for this evening on how we deal with it once it's happened. Yes, I know the horse is bolted, but that's just the focus for this evening's talk. But there is more information on prevention, but there's big bucks from big corporations there that want to sell burgers.
Fantastic. I'm conscious of time, but let's just go to one more question just to round things off. Latha writes, if a patient continues to lose steady weight with good lifestyle practices, but not achieve target healthy weight, how long can we continue to prescribe one of the pharmacotherapies, provided there aren't any side effects?
Indefinitely. Some patients, in fact, use these medications to maintain their weight. So I probably, should have mentioned that. It can be used to maintain weight, and that's a bit of an extrapolation from just a few minutes ago. We were talking about how they go on it, they go off it. Some patients you just have a little bit of Duromine or the phentermine, like the 5 days a week, and that just manages their weight, keeps it stable. Patients, some diabetic patients, if they have been on the Ozempic, the semaglutide, and they have actually lost a significant amount of weight, but the semaglutide is still managing their glucose, we actually reduce the dose back of the semaglutide so that they are not losing the weight. Their weight is maintained, but they're still deriving the benefit of the glucose control out of the same medication. So they're not at that higher dose to lose weight. We're actually using the same medication just for glucose control.
Fantastic. I think that really sums it up nicely. And with that, I'll draw this evening's webinar to a close. I'd like everyone to join me at home in thanking Dr. Simone for taking time out of her valuable schedule this week to share with us the clinical guideline updates.
That's fine. I appreciate it. And thank you to HealthCert. Thank you to you, Campbell. And I hope we've all learned something from tonight's webinar.
Thanks again, and everyone have a good evening.